Ladies and gentlemen, we're going to move swiftly on. We've got a really tight program, so we're going to keep to time. We're now going to have a look at delivering clinical pathway optimization, and to take us through that, we have the Managing Director of Primum Digital Limited. Let's give a nice warm conference welcome, please, to Nathan Moore.
Everyone, thanks for having me here today. So my name's Nathan. Background, I was an orthopedic surgeon for 8 years in training, and I found the frustrations in the front line particularly frustrating, and I went on a mission to try and improve patient care at scale. So the platform I'm going to talk about is Crosscover. In summary, it's a customizable clinical pathway optimization platform, interoperability at its heart, so FHIR-based. Yep. Higher? Sorry, can't hear me. Essentially, so clinical pathways can be redesigned to fit exactly the problems that the front line are facing. So not too dissimilar to getting it right first time. 6 years ago, I went on this mission to try and get our experts to work together at scale to sort of consolidate their knowledge into clinical decision support flows that actually go into the workflows so front care workers can get it right every time for their patients. So the challenges, you've heard about them already today. Massive bottlenecks and efficiency on the front line. And a huge part of this is just trying to get it right, get the best practice done every time is really hard. As a surgical trainee, I was put under pressure a lot of the time to do research, trying to find out what should we be doing for our patients. But if you do an audit on practice, you'll find a lot of the time, maybe half the time, we don't do what research is telling us to do. There's this huge cognitive dissonance or this big gap going, well, we know what should happen. Trying to get your average nurse, doctor, healthcare professional to actually follow it at point of care is really hard. So this just results in a massive variation in practice, lots of patients getting care potentially they don't need, investigations and follow-up that's unnecessary. So I haven't been a practicing clinician now for 3 years, but there's a few days that stand out in my memory. One of them was my first day ever on call as an SHO. It was at a Northwest London teaching hospital, and I was put on call for surgery for urology, general surgery, orthopedics, major trauma, and vascular surgery on the weekend of the Notting Hill Carnival. So I had a pretty rough day. I probably got a referral every 10 minutes, and I felt like a complete failure because I couldn't make the decisions like a surgical reg would for all these specialties at the same time. That job is now done by 3 people, but it got me thinking, how could we make this slightly better? And I went on my surgical training. I was sort of learning by osmosis how you manage these complex patients. And I was then in an operating theatre doing operations alone I haven't done before, sometimes unsupervised, and being interrupted, asked what to do with these patients in ED. And that has its own level of stress. So whenever I went through my training, I was just building up an algorithm in my head of how do I manage all these scenarios. So I thought, why can't the people in ED have this algorithm so that the patients get the decisions made faster and better? So we built a solution. It's a cloud-hosted force multiplier. First of all, to fully map out those processes locally. It could be seen as a quality management system for healthcare or an interactive textbook. So this is looking into the mind of a consultant. This would be an algorithm for managing ankle fractures. Now, that's not going to fit on a poster on a wall. It's not great as opposed to you can't tell if people are following it. So we display this like this. So say a patient's presented to their GP with shoulder pain. The GP will work through this with the patient in clinic, taken step by step through how you'd make a decision as a consultant. You know, what are the emergency red flags? This is what they are based on national guidance. Are there any present? Yes or no? Here's the amber flags. Are any present? Yes or no? Is this actually musculoskeletal pain? Is it neck pain or shoulder pain? So we kind of don't really expect any knowledge at the front line. We sort of assume there's going to be a normal distribution of knowledge and just explain it or break it down to its fundamental steps, just try and get everyone singing from the same hymn sheet. And at the end of a pathway, you've got an endpoint, which might be patient-initiated follow-up with the same signposting messaging for patients. So if you've got 5,000 GPs managing back pain, they're all giving the same messaging to those patients. And we all deserve, as patients in this country, to get the same care, no matter where we present to in the NHS. So we also have these filters at the front door to make sure the right care is given first time. But when a referral is then required, we can package up that referral through a structured referral form to go into the National E-Referral Service. And then at the other end, in secondary care, we can pull from ERS those referrals, match them and put them in a single work list alongside paper referrals. So your consultants in secondary care have single work lists for prioritization and onward management of all their referrals. We do the same for emergency care as well. So we went beyond the filters and we built a full system for managing the flow beyond first point of care. So patient management boards to prioritize and work through the patients, book them into theatres, book them into clinic, and a lot of patient-directed booking as well. We find there's lots of little innovative steps in the platform we've built it's been built by clinicians from the ground up. So it's now an EPR, but it started off through optimizing the workflows, and the EPR was on top of it. So this is kind of an example of how we'd redesign a service. So on the left-hand side, you've got the decision support flows at point of care in primary care or secondary care that try to work out what is the best next step for this patient. If a referral is needed, package up and optimize that referral. They can go into an incoming board, which can notify individuals for emergencies, or if it's an elective one, it's just, it doesn't need to do that. And you can connect all these components together, a bit like a Lego set, to solve any clinical or clerical workflow. A big difference we have to the likes of Epic and Cerner is if you wanted to update a clinical form, say a pre-op assessment form in Cerner Epic, it's going to cost £1,600 and take 6 weeks. In ours, you can log in, update it in 5 minutes and deploy it. It'll trigger a sign-off process to the other doctors in the approval policy, a bit like DocuSign, and it doesn't cost any more money. So you get really rapid quality improvement and an agile approach to clinical pathways. And on top of this, a huge analytical layer. So as we measure the flow of patients through all your pathways at an ICS level, we've got real-time budget and carbon impacts analysis. So you can tell, well, how much carbon has this pathway costed over the past 6 months? How much money? We've made this change. Has this improved it? And here's your reports and KPIs on that. And importantly, we hook into a patient-facing app, accessed via NHS Login, the NHS app. So you can have automations sending automatically pre-op assessments, digital consent at any trigger points along this flow. So the patients are really engaged in the whole process. In lots of ways, we've kind of created what I call DevOps for clinical pathways. This is a concept of software engineering that's well known. We give the ICS or the trust a development environment in the front end. So your clinicians can actually own and update the pathways to like a visual builder. They can test it and put it through a controlled deployment process, which has version control and audit log. And then importantly, we then can integrate directly into the primary or secondary care EPRs to launch from them through Smart and Fire. Or we can be the EPR. We kind of fit around it. It's very modular. And importantly, monitoring engagement as you go and the analytics component on top of that, with the whole aim to improve clinical effectiveness. So behind the scenes, this is an example of the pathway editor. So one of your consultants with the permission to go into this pathway would go in and be able to edit this pathway behind the scenes, every component in it. As it's cloud-based, accessible on laptop, phone, iPad, you can see behind the scenes, like, it's just an algorithm, right? But your consultants can change every component. And they get really excited about this because they can go, wait a second, Nathan, I can just change this. Then my consultant colleagues can countersign it. Then it will be in my ED 4 seconds later after it's signed. I think the time it takes normally to change a guideline and get a poster or a leaflet or a document no one's ever going to read put on the trust intranet takes far longer than that. We've had consultants sit in conferences like this, see a new bit of evidence presented, open their laptops, update the pathway to the new evidence, have their colleagues countersign it, and then it's deployed in their ED the same day. We also had the new spinal pathways came out from GERFT, and the Birmingham team managed to deploy that into their practices within 24 hours of that pathway being updated, which is a real change to normal process. We've got AI built in that can help write pathways for the clinicians so they can validate what the AI is producing. So case study-wise, we contracted to standardize the pathways for all of Birmingham and Solihull. It's the largest ICS in the country for MSK, so a third of their workload. So they did a service evaluation where they created like an OSCE scenarios for hip pain, knee pain, back pain, and knee pain. Got GPs to see patients with or without our intervention, measured the time patients walked into the room, out of the room, what decisions were made. Because we all know there's variation in practice. But what they found was the average consultation time in status quo across 152 scenarios was 11 minutes 40 seconds. But with our intervention, it was 7 minutes 22. If you think about this 300 million primary care appointments for MSK a year, and you can shave 30% off the GP time to see those patients, while at the same time getting best practice going up from a quarter of the time to almost 100%, reducing unnecessary appointments from happening half the time to almost none of the time. And they're also ordering unnecessary investigations a third of the time. So the financial and carbon cost of that is huge. We have had health economics done, funded by NHS England, in the southwest, looking at some of these musculoskeletal pathways, and it says about £100 per patient is the average saving for just getting it right first time. That shouldn't be surprising to anyone in particular. So in summary, we're over 50 sites at the moment, probably about 200 NHS sites by the end of the year. The average time from entering a pathway to reaching a consultant management plan is 35 seconds. We probably cut secondary care appointments about 50%, depending on specialty. We can deliver scale or change, quality improvement change, in a way that I haven't seen before, because we give your consultants and your clinicians the tool to do it. We do all the information governance, clinical safety, it's a medical device, it's interoperable, all the boring stuff, we do it to give your clinicians and empower them to design the services they want done. So we've got a randomized control trial going on at the moment across Birmingham and Solihull, funded by NHS England. It's a non-inferiority trial as we activate GP surgeries in clusters, comparing status quo to intervention. That's an extension on the service evaluation that was done as the pilot. So this is going into the analytics. So because we know in real time how many patients go down every flow in a pathway, we can assign carbon and financial codes to every resource. And then on that, we can then say, you wanted to know in the past 6 months for our back pain pathway, how much did it cost? We can tell you. There's no cost. There's no £100,000 for an economist to come in and do it. We've got the models already built in. So you get that level that you want as execs for reporting to make sure what you're doing as a sort of a bonus, while at the same time fixing the fundamental problem that your clinicians are facing every day. So in this process of going from a clinician to commercialising in the NHS, I've learned quite a few things. One is winning hearts and minds is just so important. So I have quite good success with clinicians. Clinicians see it and they just get it. But that's another point. So supporting NHS champions. When I do find someone in the NHS that just, you see that light bulb moment, they just absolutely love it, we work really closely and make sure that I write the business case, I meet IT, I meet IG, I meet clinical safety, I do all the work, or my team does, to sort of help that clinical champion fight all the battles that have to happen subsequently. I have learned to be incredibly agile. You'll notice from the way the software is designed, it's agile by default. It can be adapted by your clinicians all the time. But as a company, we operate on 2 weekly design sprints, so we'll be able to build a feature in a few weeks that will take other companies 6 months. And we always listen to feedback from the front line. Top down, bottom up. So as mentioned already today, I found you have to have support from the ground up, so your clinicians, your ED consultants, your specialist consultants saying we want this in, and then I would help put the business case together to go to the top. But now I'm getting a situation where execs are coming and saying we want this because of the carbon reduction, etc. And I'm saying that's great, but you need to talk to your clinicians at the ground up so that they buy into it as well. So in summary, we can help improve clinical effectiveness, improve efficiency, optimize patient outcomes, and deliver low carbon models of care that are sustainable. We're over at a stand just over there, happy to talk about anything in detail or take any questions you might have, but thank you very much.
Thank you very much, Nathan. We've got a bit of time for any questions. Anybody like to ask Nathan anything while you're getting your juices flowing? Perhaps I could start. What is the reaction of clinicians to this? Because I mean, I was impressed when you put up the care pathway and the algorithm that doctors carry that kind of thing in their head. How do they sort of feel about the fact that you're effectively telling them how to do their job? I mean, my experience in the NHS is that that's not an easy thing to do. how do you build that relationship?
That's a really important point. So whenever I get a phone call from, say, an orthopedic consultant saying we want this in tomorrow, I'll say that's great, but you need to go talk to ED and you need to come together and work on these pathways together with us, because you don't want it to be seen as a stick to BTD with. It's a collaborative approach. We did have a qualitative assessment to the health economic reports, and some of the anonymous reports back were things like ED consultants saying it was unnerving to find what I'd done for 20 years has been out of date at such a massive scale. So they were getting, say, 120 modern pathways of care deployed, and they're just having their... It could be quite unnerving. Do you think you know what you're doing sometimes? And it's very easy in healthcare to get it wrong for a very long time because no one's really got time to tell you. It doesn't necessarily mean patients are coming to serious harm, but it means they're maybe coming to clinics they just don't need to go to. Like when I used to do fracture clinics of 70 patients, and I see a patient every 10 minutes, if you have a difficult conversation that spills to half an hour, you're always behind. So if you see a toe fracture coming in without a displacement and you think, why is this person here? You don't have time to go and phone the person that referred it in and then get a complaint that you're being difficult. You don't have time for that. So it perpetuates for years these sort of inefficient pathways. Does that sort of help answer that question?
Yeah, it does. And how does the interface work between the clinician? I mean, how is it? What is it like to actually use this? How is it physically used?
Yeah, so we could launch from Epic or Cerner from patient context, and the doctor can go through the flow, either with or without the patient. In primary care, the GPs tend to turn the screen around and work through it with the patient. Quite a lot of the time, there's questionnaires in there for the patients to work through structured with the GP. And then at the end, of that engagement, the final plan will get sent through a link to the patient so they can go home and share with their relatives and read over what that advice was and how they came to it. Because you know what it's like as a patient. You sit there in a conversation and you're like, what did he say? And your relative's asking you, what's the plan? And you're just like, not really sure. So with the entire message is given to them.
It's really interesting because there is research that shows, I think, if I can remember rightly, I think it was York that did it, and it was some astonishing figure, something like 90% of people who'd had a consultation with the doctor that morning couldn't remember key issues that they'd had, because your mind just goes a blank. And so I think the take-home bit of this is really interesting, isn't it? Have you got? Can you tell us some more about that? I mean, that's.
Yeah, so we've got a sharing component at the end of every pathway where a little QR code appears on the screen, the patient can snap it, and they've just got on their phone a link to all the advice they got.
So just take us through that again. So at the end of the consultation, up comes a QR code, you can snap that, and that gives the patient access to what they've just seen.
Yeah, exactly. Yeah. That's one way. Or if they've used the patient app, the patient can log in through NHS Login and see their whole encounter in there as well. There's multiple ways to do it, depending.
So you could connect this to the NHS app, for example?
Yeah, so it launches from within the NHS app. So the patients don't have to go to a separate app. The NHS app, if we were in the local for their general practice, we
And you can do that now?
So in about 2 weeks we can do that, yeah.
It's Joe Henderson, isn't it, who's leading on that?
I haven't met Joe.
Yeah, no, we got a guy that in the NHS whose job it is now to beef up the NHS app, because it's kind of a nice thing to have, but it's pretty useless, really, other than just repeat prescriptions. Sorry, did you want to say something? Yeah. We've got about 3 minutes.
Thanks. Thanks, nice speech, it's really interesting. Safety netting, misdiagnosis, and how do you fit in with national guidelines?
Okay, so...
Did everybody hear that? Yeah. Safety net and misdiagnosis. Never happens. Never happens. What are you suggesting?
So this is a multi-stage answer, I suppose. So clinical safety is of paramount. So we've got clinical safety officers, clinical safety case reports. If you look at status quo, what happens normally day to day is large numbers of patients receive treatment that may have ongoing problems for months afterwards, right? So you've always got to compare intervention to status quo. In our clinical safety case report, we're seen as a control to status quo. So inevitably, the clinical health professionals are told this is decision support. You can still escalate up your normal routes of care if you're unsure. And we also have built-in post-deployment surveillance for the locality that deploys it. So once you deploy a pathway, There's a report issue button, so any member of staff can report an issue with the content. That might be an actual clinical issue with the flow, or it might be an operational problem, like you want us to put this splint on the patient, we don't have it on the shelf. Then the people that write the pathway can then put a business case in going, we do actually need this splint. So that continuous feedback loop in governance. It's also a medical device in terms of its manufacture. So I think that potentially answers some of the questions. We also partnered with NICE 3 months ago, so we've got all of NICE's guidance embedded in the platform as well, if that helps.
That's really interesting. Nathan, I think we're up against the buffers of time. Can we say thank you to Nathan? And have you got a booth here? Are you on a stand?